Fuchs endothelial dystrophy is one disease which can affect cornea in elderly people. And today we will see this disease is its clinical profile and also witness a cataract surgery being done in one such patient. So Fuchs endothelial dystrophy is a non-inflammatory sporadic or autosomal dominant dystrophy which involves the endothelial layer of the cornea, and over the due course of decades the cornea gradually gets edematous and there's bullous keratopathy which causes diminution of vision, halos, and reduction in the visual acuity. And this is inherited in an autosomal dominant fashion, and there may be sporadic mutations where there is no family history, but the offsprings of a person who is affected with this disease may have 50% possibility of both male and female children being affected by this disease. So the risk factors are, apart from the genetic susceptibility, the risk factors which have been studied are smoking, but the higher weight and body mass index that decreases the risk of having corneal guttata or endothelial dystrophy early stage. It uniformly occurs in the age group more than 50 years of age and is very rare at the age of 30 or 40 years, and it is seen commonly and earlier in women. The clinical features of this disease are the cornea guttata, which are basically excrescences on the inner surface of the cornea which appear like this, and they are seen on a microscope as a mushroom caps on the endothelial surface of the cornea. This is one slit lamp image which shows cornea guttata. The endothelial cells, when seen on specular microscopy, can be seen as larger than average, and they are deformed, and they are cornea guttata seen in between the cells. And this is one photograph which indicates one such scenario where there are normal cells versus, so these are normal cells which is versus the endothelial cells as seen in cornea guttata and endothelial dystrophy. As the disease increases, there's increased thickness of the corneal stroma, which gets gradually opacified, which causes glare. And this edema is basically has a variation, and it increases just before the sleep, and patient can see the vision is blurry at the start of the day, and as the day passes by, this blurriness decreases. So there's a fluctuation in the corneal edema and associated diminution of vision. When one starts having epithelial bullous keratopathy, the situation becomes worse and patients start having foreign body sensation. This is one photograph which shows the epithelial cells swollen up because of the edema. As the disease progresses, there's a chronic edema in the stroma and epithelium which causes fibrotic tissue which will form in the subepithelial space and invade the cornea, leading to further corneal opacification and permanent scarring of the cornea. The symptoms will range from glare and diminution of vision, which will start in the late 50s of a person, and the glare has a fluctuation that it is more during the morning hours and reduces during the afternoon and evening time. Foreign body sensation, watering, and diminution of vision further progresses as the disease progresses, and patient may become uncomfortable because of these symptoms. Once the scar formation occurs, then there is diminution of vision, which is far more severe, and patient may have chronic irritation and watering because of the epithelial bullous keratopathy. So here we have one case in which this patient had Fuchs endothelial dystrophy, and it was suspected so because the other eye, which had already been operated upon, had a decompensated cornea with bullous keratopathy, as we can see here. So this was essentially a only eye patient and was very worried about the outcomes in this eye when I discussed that this is because of an inherent issue here. Now this is one very useful conjunction which can be used during the cataract surgery in such patients, and this is sodium hyaluronate along with chondroitin sulfate. So this is a very good combination which coats the endothelium well and protects it during the surgical maneuvers. So here this has been injected inside the anterior chamber, and now we are proceeding for capsular access. Now when I had planned this surgery for the patient, it was a mutual joke among us that your boat या आपकी नाव में छेद है एंड हम लोगों को इस नाव के डूबने के पहले पहले उसको उस पार ले जाना and this was a mutual joke between us so that if the surgery is successful and the corneal endothelium is preserved well, the patient will gain good vision. Otherwise, the patient may end up having edematous cornea and subsequently will need a corneal transplant. So few things which I kept in mind were that I would have to perform this phacoemulsification at a deeper plane when compared to any other patient and not to disturb endothelium. And for this, I also planned that I'll bisect the nucleus into further small chunks so that none of the chunk is large enough that it reaches close to the endothelium when I'm emulsifying it at a pupillary plane. So here instead of dividing my nucleus into two halves and further into four, I have divided my nucleus into 6 parts, each quadrant divided into 3 parts so that the chunks are smaller and they have a less vertical reach. Now half of the nucleus has been emulsified, and I also took care that in between the procedure I made it mandatory that I would replenish the chondroitin sulfate and sodium hyaluronate viscous gel so as to coat the endothelium well so as there's minimum possible damage to the endothelium. One key element is also to keep the direction of the irrigating fluid horizontally so that it is not hitting the endothelium. Now again proceeding for the further emulsification of the remaining nucleus. As we can see, the nucleus has been divided into again 3 smaller chunks and they have been consumed under the protection of the second instrument, that is the chopper. The chopper will be kept over this particular chunk of nucleus so as it doesn't hit the corneal endothelium. Now these maneuvers are important if we want to preserve the endothelium and not to cause further loss of cells. Any surgery, phacoemulsification or manual small incision cataract surgery is going to cause some amount of loss of endothelial cells, and this is a known phenomena, and this would range from 10% to 30% depending on the scenarios. Now the nucleus has been consumed and now we are proceeding for removing the remaining cortex. Now here we don't use any phacoemulsification power, although it's important that we should remain away from the endothelium so that there's no touch or damage to the endothelium in any way. Again replenishing the anterior chamber with chondroitin sulfate and sodium hyaluronate solution and preparing for implantation of a single piece monofocal hydrophobic intraocular lens. During whole of the time of the surgery, the patient was cooperating well, although she was very apprehensive about the outcomes. And to be honest, even I was a little apprehensive that knowing that there will be some loss of cells, how is it going to end up for the patient? The intraocular lens has been implanted and is being dialed into position. Proceeding for removal of this viscoelastic gel, which has both the elements, that is sodium hyaluronate, which is supposed to be a cohesive viscoelastic, and chondroitin sulfate, which is adhesive viscoelastic. So in toto, we need to take care that the sodium hyaluronate is supposed to get washed out easily, but chondroitin sulfate will need some time and some maneuvering so that it is completely washed out. I also didn't want any IOP rise at the end of the surgery or further down during the 24-hour period, because that is going to increase the corneal edema. Now the surgery has been finished. We are inflating the anterior chamber, and before that I am trying to flush out any remaining viscoelastic which has been left behind. And after the end of the surgery, this is the day one where we can see some amount of stromal edema, epithelial edema, and vision was just finger counting. However, the patient recovered well, and at 7 days the patient vision was 6/12 and the clear cornea was very, very clear. And this is another such photograph of the same day which shows a very clear cornea and a very satisfied patient. And this is the other eye which is supposed to be handled by my corneal colleague, who will take care of the cornea and possibly do a keratoplasty for improving the vision in this eye. Although now patient is very happy and satisfied and was not very keen for the operation of the other eye, but let's see. Thank you.